Hi there, and welcome back to the Dutch Podcast. I'm Dr. Jacqueline Smeaton, and on this podcast, we dive into the vast and ever-evolving world of hormones as part of our lifelong pursuit of better health. Here at Dutch, we've dedicated over a decade to transforming lives by addressing hormonal imbalances like cycle irregularities, perimenopause, menopause, and more. Our mission is clear: to simplify and advance hormonal health for everyone. On this podcast, I get to bring you cutting-edge insights from our top experts on hormone therapy, menopause, personalized medicine, and more. We're all aimed at making a real difference in your well-being. Your questions and feedback are crucial. They shape our discussions and help us navigate the complexities of hormone health together. Now, as always, please remember, the content of this podcast is for educational and informational purposes only, should not be considered medical advice. Be sure to consult your healthcare provider for medical advice, diagnosis, and treatment. Hi, and welcome. Now, joining us today, we have an expert in menopause who I really trust and love to talk to, Dr. Tara Scott. Now, Dr. Scott has incredible experience as an OBGYN and a really open-minded approach to care, but she's really got a good sense of the literature as well. In today's episode, we are going to talk specifically about HRT and breast cancer risk, but really our conversation rolls into all kinds of things around HRT, how it's put forward, what her clinical approach is, and really how critically important it is that 100% of women at least have the opportunity to understand the risks and benefits of HRT for them. We talk about how to find the right provider. We even share how providers can get better education. So you are going to love this episode start to finish if you're into menopause at all. Now, our guest, Dr. Tara Scott, graduated from Northeast Ohio University College of Medicine and completed her residency with Soma Health Systems at Akron City Hospital in Ohio. She recently retired from traditional OBGYN after almost 20 years to fully focus on functional and integrative medicine. She also acts as an associate clinical professor at Northeast Ohio Medical University. Dr. Scott is a certified menopause practitioner with NAMS, the North American Menopause Society, and a fellow of the American College of Obstetrics and Gynecology. She really became involved with hormones and integrative medicine when she practiced as an OB-GYN. Because her empathy for patients experiencing hormone-related issues, it really led her to be trained as a more advanced fellow and to become certified by the American Academy of Anti-Aging Medicine. In 2015, she obtained an additional board certification in integrative medicine, and she's been consulting with companies in the industry since 2020, really focusing on the hormone, wellness, and menopause space. She's done so much work in this area, and you'll notice right away she's so passionate about menopause. Really, her role is to educate the medical community on the advances in hormone-based therapy, and she lectures all over the world on these topics. She's been educating for over 10 years. She's taught doctors across 5 continents. She's been featured on so many different media outlets, and today we're really lucky to have her here. So let's go ahead and get started. So Dr. Scott, thank you so much for being on the Dutch Podcast again. It's always so nice to get the chance to talk with you.
You're welcome, and thank you for continuing to get the important information out there.
Absolutely. So, today we're going to talk about a lot of different elements of HRT, particularly around breast cancer, because it is Breast Cancer Month. But I'd love to start by just sharing, if you can just remind listeners or people who are maybe new to this because of a breast cancer history they've stumbled upon this talk, or breast cancer risk. Can you just share a little bit about what is HRT and really what are you seeing doctors utilize in the healthcare space?
Well, certainly it's interesting how HRT is in the news lately because Gwyneth Paltrow and Halle and Drew Barrymore and all these celebrities that are going through menopause or have gone through menopause. So it's definitely getting the media attention. 20 years ago, there was a study that was probably the wrong study in the wrong patient in the wrong cohort with the wrong medication and medications we don't really use right now, and really scared a lot of people from using hormone therapy. And I think if you pulled 10 family practice doctors, 10 of them would tell you not to take hormones. And I think actually probably 9 OBGYNs would probably tell you not to take hormones. So hormone therapy is any replacement therapy, and they don't even want to say replacement anymore. They want to say hormone therapy is supposed to be a duplication of what your body produces. So your ovary produces estradiol and progesterone, a little bit of testosterone, and traditionally a form of estrogen and a form of progesterone had been given. Now, in the past, they were more similar to birth control pills because those are synthetic. And the whole point of birth control pills is to prevent pregnancy. So when they were trying to make hormones way back in the 1940s, they didn't really know how to make progesterone in its natural state. So they made a synthetic version of it. Nowadays, we have many, many FDA approved what we call bioidentical hormone therapy. And the word bioidentical, all that means is that it's chemically, structurally the same to our bodies. So, for example, we have sugar and we have Splenda and sucralose and saccharin, right? We have all these artificial sweeteners that all they do is sweeten your coffee. But if you're a diabetic with a low blood sugar and you took one of those like Splenda, it wouldn't raise your blood sugar. It would do nothing, right? It just sweetens your coffee without any calories. So that's kind of how I explain to my patients the difference between bioidentical is chemically the same as what our bodies produce. There still are synthetic hormones available, and the bioidentical hormone doesn't mean they can't be synthesized in a lab. When I was a resident, we used to give beef and pork insulin to diabetics. So some people would have like allergic reactions to the beef or the pork, right? Well, now someone figured out in the lab how to make human insulin. So we give patients human insulin. We don't get insulin from other donors and make it. Mm-hmm. Someone makes it in a lab. So it's the same as hormones. And so bioidentical hormones just means that it's the same as our bodies.
So it is interesting that you bring up the whole like hormone therapy versus hormone replacement therapy. And that was emphasized actually really recently. NAMS, the North American Menopause Society, released a statement because they had an event. And at the event, there was so much chatter amongst the attendees that there is a tremendous amount of misinformation circulating online. So they released a statement really to re-emphasize the points that they've always made. But I think it's worth kind of talking about those. That first one that's so interesting feels probably the most controversial to me, which is that we've always called it hormone replacement therapy. And they did too for a long time. But now they are calling it hormone therapy for the following FDA-approved indications, saying replacement is not necessary in menopause. So let's start with that comment. How did that land for you when you read that?
Right. I know. So the first thing, it's so interesting because, we don't get the same guidelines about men's hormones, right? And so for men's testosterone therapy, there's much broader indications to use it. For women, for hormone therapy, the first point that the Menopause Society made was that it's not necessary to do it, right? And so I think because of social media, maybe there are some influencers, or maybe there are some even just people who are normal people that ended up being influencers because of their experience that they've shared on social media. There may be interpreted that you have to take it. And so I believe 100% of women should be told of the risks and benefits. They should have their own personal history and situation assessed, and they should have the opportunity to choose to take it. But I wouldn't go so far to say that every single person needs to take hormone therapy. I just think everybody needs the opportunity to be evaluated and know of the personal risks and benefits of hormone therapy. So it was pretty clear by that statement that that they were advising hormone therapy is indicated by the FDA for 4 indications. The first is what they say, moderate to severe vasomotor symptoms. So that, I don't know how you define that, if they've actually said, 20 hot flashes versus 10 hot flashes, but moderate to severe to me means that your hot flashes are disruptive, right? 2 is prevention of osteoporosis. You can't say treatment, prevention of osteoporosis. And I think they even, correct me if I'm wrong, Jacqueline, they might have had a qualifying age for that, because I know they designate premature menopause as the yes. third indication. So it's menopause before the age of 45. So primary ovarian insufficiency is now called, it used to be premature ovarian failure. Primary ovarian insufficiency is before 40, and premature menopause is before 45. Natural age of menopause is 52. So the recommendation from the Menopause Society based on their 2022 position statement is that if you're somebody who's had your ovaries removed before the age of 45, there's more benefits for you taking hormone therapy at least until the age of natural menopause because of the markedly increased risk of heart disease. Now, we're not allowed to say it's going to prevent heart disease. And the 4th indication is genitourinary symptoms of menopause, which is vaginal dryness, painful intercourse, painful urination, frequent UTIs, pain with sex, So any of those vaginal complaints, that would be an indication for hormone therapy, according to the FDA. And so there are other benefits of taking it, but we can't say.
Yeah, it was interesting because they really kind of debunked. I thought they were a little overly strong, actually, in that section of their statement, which is like, we should not be discussing hormones for the following reasons. And it really listed a lot of the symptoms that women come to their provider with around menopause and really want relief from. The more fatigue, brain fog. I can't remember everything that was on the list. I don't have it in front
I
of
mean,
me.
it was cardiovascular health. I mean, even
Okay.
though there are
Oh,
studies
cognition.
right, it was definitely fatigue and brain fog. And I think there are many studies that show it does help cardiovascular prevention. But this WHI, which was done in 2002, failed to show for the FDA that their product, which was a synthetic version called Premarin and Provera, it failed to show that it was prevention of heart disease. And that's what that's based on. There have been a lot of observational trials, right? But for the FDA to put their stamp on it and say that, yes, it does prevent heart disease, they want a randomized placebo-controlled trial. And this WHI, everyone says it's the largest one we've had. But if you actually look at the number, it was only 8,000 people who got the drug and 8,000 got the placebo. To me, 16,000, it sounds like a decent study, but we have studies of 80,000 people, but they're observational, right? So that's the difference.
Mm-hmm. Yeah, it's so interesting because I think, in a way, when I read that, absolutely it's true. It's only FDA approved for certain indications. However, I think clinically, providers that prescribe hormone therapy really see women experience relief of other symptoms as well. So it's a matter of, like you said, that, we need to clarify these are not FDA approved indications. However, there are trials that exist that show the following, in order to tell that whole story when you're helping a woman consider whether or not that's right for her.
And if you actually look back to their 2022 position statement, I mean, they have verbiage in there that shows observational studies show that there's a 19% reduction in diabetes in patients who choose to take hormone therapy. And we all see weight gain at menopause. Women's cholesterol just jump up. I mean, I've never had a problem with my cholesterol. Boom, it just went up, and not just HDL. We're not talking HDL. We're talking LDL, non-triglycerides, but like for no reason.
Mm-hmm.
And we're talking about diabetes, weight gain. So that's well been documented. And in the studies they did out of the University of Colorado, and again, I'm guessing these were observational studies, they showed that basal metabolic rate did change with menopause. And exercise did not improve that, but estradiol patches did. Again, observational data. And I don't remember how big the study was.
Now, the last thing that was on that I wanted to get your thoughts on was the use of testosterone in women. They really clarify that it's a very narrow indication for testosterone, yet we see testosterone prescribed much more broadly. In fact, there's even schools of thought in integrative medicine and some providers who start with testosterone therapy, which I think is a pretty controversial approach, instead of an estrogen and progesterone approach. And I can see why they're wanting to reemphasize their position statement, really, which is what they did in this. But what are your thoughts about that narrow window for testosterone? And
so
of course, that's
because the Endocrine Society guidelines on male testosterone replacements says you can replace male testosterone hormones for testosterone levels at the low end of normal. Doesn't even have to be abnormal. Low end of normal for erectile dysfunction, low libido, fatigue, low mood, low stamina. Okay. And for females, the Endocrine Society says there is no condition of hypoandrogenon that exists for women. The lab ranges are not, I can't remember the verbiage, but they're not accurate because we have free testosterone levels that are 0 to 2.2 are a normal range. So 0 somehow is a normal, included in the normal range. And it says that you can't correlate symptomatology with blood results. So don't do the blood results. And it also says it's only indicated for postmenopausal women with hypoactive sexual desire disorder, which is now called female arousal disorder. So it used to be HSDD. So low libido basically in postmenopausal. And so there's quite a dichotomy as far as male hormone therapy and female. Now, having said that, there was the global consensus on testosterone that was published in September of 2019, where they looked at the world's data on testosterone. There's quite a bit of data because they were trying to market a testosterone patch at one time. And it didn't come to market because there were safety concerns or efficacy concerns. They said they didn't have enough data, but if you look at the studies on testosterone gel for men, they had this similar amounts of data. And nothing was concerning. And I think from a marketing perspective or maybe a business perspective, nobody decided to push it through. So it's not available in the United States. I think at one time it was available in Europe. I don't know if it's still available. So with that narrow indication, that global consensus said, those things, but in the last line said it does not increase cardiovascular risk in women. And 2, it does not increase breast cancer. And so that's in the global consensus on testosterone. And so, a lot of people are concerned about that. Having said that, though, like you said, it's very liberally prescribed. There are some schools of thought that believe in driving the levels, what we call supraphysiologically. So for an example, if your normal testosterone level is 16 to 55, they're aiming for women to have a level of 150. Again, it's another approach. I don't really practice that way, but that is another approach. They're using higher doses in a form called pellet, which is a super compressed hormone that's surgically implanted into your hip. And then it has to degrade over a couple months. So, and some women are feeling really good. Now, again, I can't say that's without risk because those hormones aren't often monitored as to how they're metabolized, which is one of the key things that the Dutch test looks at, right? Is how is it metabolized? And when I see people being prescribed testosterone, they're almost never looking at estrogen, which is a key metabolite of, where testosterone can go in men or women.
Mm-hmm. So. Yeah, that downstream metabolism is critical to take a look at to make sure, because one of the routes of elimination for testosterone is through estrogen and then estrogen detoxification, aromatization to estrogen, and then estrogen detoxification. So absolutely, we agree, both looking at androgen metabolites as well as looking at estrogen metabolites are really critical for anyone on testosterone therapy. And you are subtly pointing out over and over a couple times here just the differences in the grade of literature required to make a recommendation, particularly around these quality of life concerns like fatigue and libido. There were a couple other that you mentioned that jumped to mind where there is a different approach taken for men and for women. I actually didn't know that the normal range for free testosterone went down to 0. That seems mind-boggling.
It must be it depends on the lab, but it's not very far from 0. It might be 0.1. I mean, it's ridiculous, and that's free. Yes.
That's crazy. That is crazy because we do know testosterone plays a critical role even in cycling females. It's really important. It's so important.
Yeah, it's not really just that's not really just libido, and it's not hair and skin and nails. There's actually studies of women who had lower levels of testosterone, and they extrapolate out for diabetes, heart disease, and they still had higher levels of death, mortality rates. There's studies where they gave testosterone to elderly women with heart failure, and it improved their ejection fraction. Because if you think about it, testosterone helps your muscles, and the heart is a muscle.
Right.
So I think there's just so much misunderstanding, and it just goes down to your approach with anything, right? Because I could sit here and say, only if you're feeling terrible, I'll give you hormones, which that's not really my approach either. Or I could be like, hey, let's juice you up. And, there's hormone people who think you should have a period till you're 80. Let's give you enough estrogen so you have a withdrawal bleed. And let's give you this level of testosterone. And it exists in any space. Look at our weight loss space now that there's people taking injectables for 5 pounds, whatever it is, you know what I mean?
So one thing that I think is interesting and will be interesting to follow is that particularly around safety data and testosterone is that now we have this whole body of literature coming out for trans males, which are individuals who were born biologically female, assigned female at birth, and go through a hormone replacement therapy process to become a trans male. And that is incredibly high doses, much higher than we'd ever use for a menopausal female, because the intent is to produce, male-like symptoms, different patterns of hair growth, muscle growth, et cetera. So that literature is really starting to grow around safety and around outcomes. And those are at multiples of the doses that would be used that we're talking about here. So I'm really curious to see how that bears out over time, because it's going to be difficult to deny at least safety. Maybe the need for testosterone would still be debated, but the safety data for testosterone for women should be made pretty clear. Or if it's not already, I haven't looked at that literature yet, but we should
and
be seeing more
according
and
to
more.
this global consensus in 2019, there was not a concern about heart disease and cardiovascular and breast cancer. They didn't put dosage recommendations on there, right? So they didn't say supraphysiological doses will or won't. So that will be interesting. There have been some studies on pellets, which is generally supraphysiological, that there wasn't an increase in breast cancer. Specifically, I haven't pulled the literature for cardiovascular or anything, but actually at the conference you and I were both at, I think she did speak about that, and there didn't seem to be an increased risk of cardiovascular risk with women using pellets. So, but I mean, as anything in our space, you really have to treat the patient in front of you. We say N of 1, meaning like, what is your personal history risk? And that's why I think it's important to know how everyone metabolizes hormones, all hormones, cortisol, estrogen, testosterone. And I feel like everyone at some point, if they're able, should do the dry urine test to look at their pathways, because those are genetically influenced. They're augmented and induced by other external factors. And it's a critical piece. After being in the industry for 30 years, of what we missed, what I missed when I started doing hormone therapy.
That's great. Thank you for that. And I think you're absolutely right. So I want to shift to the breast cancer piece, which is really the intent of what we're talking about today. But I appreciate you sharing your thoughts on this kind of more current release. And we will link to that in the show notes if you're a provider and you want to read it. And I think really the underlying sentiment of misinformation on the web is very real. I see it all the time. I see, nutritionists who come online or health coaches who come online and say every woman should be on hormone therapy. And of course, those broad sweeping statements are never true or very rarely true. But I love the way you position it, that 100% of women should be told about this option as they transition through perimenopause into menopause, and have their individual risk factors assessed so they can really understand whether that's a positive thing for them or whether that would be a risky approach for them, and whether they even want it. But I love the way you say 100% of women really deserve to know. I couldn't agree more.
You're absolutely right about the misinformation. I mean, I've seen people post that there's no increased risk of breast cancer. And, going by the guidelines of the Menopause Society, we have to quote, and I quote all my patients, 3 out of 1,000 is what the risk is thought to be if you choose to use Prempro, which I don't prescribe, but 1 out of 1,000 for bioidentical. So not a percent, but 1 out of 1,000. So you still have to say there's that risk. How do we know in the patient that we're seeing that there isn't already a cancer brewing there?
Right. Well, and studies only go out 5 years, right? So as far as what is, when can we really say that with authority? Guidelines say in the first 5 years of use.
Yes. And, if we look at the statistics of 1 in 8, having a breast cancer risk, and about 13%, somewhere around 13 to 20% being genetic. Well, now people are getting their genetic predisposition. If they know they have a family history, there's more and more with genetic testing, which is great. And women are acting on that. But yes, I don't think you can never say there's no risk of anything.
Right. Yeah, of course. One thing about the WHI, the study that you talked about at the beginning that really set the negative tone around hormone replacement therapy for females, is that they put relative risk in that paper, not absolute risk. So they showed it as like percent increase from a woman not on therapy to a woman on therapy. But it was almost like a disproportionate. It set the wrong tone for the results because, like you said, on therapy, it was like 1 in 1,000 women, which is, although the relative risk went up, the absolute risk was still very, very low.
Yeah. And that's, when you see the data published on estrogen only, and I know this is a debate on breast cancer, and I will eat crow if I have to, but I feel like estrogen only is a risk for breast cancer. The statistics of people who took placebo in the estrogen only arm of the WHI that got breast cancer was 0.35%. And the women that got breast cancer on Premarin was 0.27%. That's the difference. That's the decrease. It's not even 0.5%. And that's what they're broadcasting. That was the percentage. Now, I'm not a statistician. I don't know how you do relative absolute risk p-value. Was it statistically significant? But everyone I talked to is like, there's no risk of breast cancer with estrogen only. I do feel it's a risk. It is very concerning to me because that was 5,000 people in placebo and 5,000 people that got the drug that were 65. But we have the Nurses' Health Study that was 122,000 people, younger women, that the longer they were on estrogen only, it was like 10 to 19 years was 15 to 20%, and longer than that was up to 30 or 40%. And don't quote me on the percentages, but it was large percentages of increased risk of breast cancer. And then we have the E3 EPIC cohort, another observational trial, but 80,000 women, 40 to 64. And in the women that took estrogen only, and most of that estrogen was transdermal estradiol because it was a French study and they weren't using oral estrogen, they weren't using Premarin. They still showed an increased risk of breast cancer in estrogen only, and that lasted 8 years. So it concerns me. What we know about the uterus is we would never give estrogen only to somebody with a uterus. And if you go to my textbook that I had in residency on reproductive endocrine and gynecology, our author, Dr. Spiroff, says the breast and the endometrium are similar cells. Like you can even see studies, one study by Stanzik, that people with endometrial cancer had an increased percentage incidence of breast cancer. So I am not with the standard of care, which is to only give estrogen to people with no uterus. And that concerns me. But I mean, if there was another recent study that was published that said there was no increased risk. I don't remember the details of, it was a retrospective chart study, I believe. But Romanowski, I think was the lead author, and they did a retrospective chart study. Now, I don't know. And the other theory that I can't corroborate is that in Premarin, because there's a lot of things in Premarin, there is some progesterone. There's like 500 things in there. So is there some progesterone in conjugate equine estrogens that's giving some protection versus estradiol only? I don't know, but I feel that as a risk factor for breast cancer based on those 3 larger observational trials and based on my textbook. So
now, when you say you're not with the standard of care for estrogen only for a woman without the uterus, what you mean is that you would still consider giving progesterone to a woman without a uterus for breast cancer. Thank you. Yeah. I just wanted to make sure we said that out loud so that that's exactly what you'd meant.
When I prescribe estrogen, I always prescribe progesterone. I have a few patients that cannot tolerate certain forms of progesterone, so we may pulse it and find a form that is acceptable for them. But as soon as you get a breast biopsy done, you have an estrogen and progesterone receptor, and that's what we send to pathology as well as HER2/neu. So everyone gets the receptor. So there is a progesterone receptor in the breast. There is a progesterone receptor in every cell of your body. So when you say you're replacing one hormone without the other, it'd just be like you took your money and you put all of it in the stock market and you didn't have any real estate and you didn't have any savings account. I mean, the stock market is so volatile, you could lose your whole, there are different types of investments, right? So why would you not diversify, right? And so there's one hormone versus 3 or potentially 4 or 5 that our body produces. So
that's great. I love that analogy.
Because the standard of care and what is traditionally acceptable is to give estrogen only after, because I think that came from the WHI where the progestin group increased the risk of breast cancer. And then they started blaming it on the progestin, which was Provera or medroxyprogesterone acetate. And there's several studies that do confirm that actually increases the risk of breast cancer. So they don't understand the difference pharmacologically, physiology of a progestin and a progesterone. That's the problem. So don't give a progestin to someone without a uterus.
Now, there are a couple of small French studies that look at progesterone and impact on breast that aren't really widely talked about, but do seem to show that it is a safer alternative to a synthetic progestin when it comes to breast health.
There's actually a lot of studies, but I don't know that any of them are randomized placebo-controlled trial, right?
And they're observational. The ones I've seen are observational.
Yeah, that's the problem. And
so we just need better data.
Can you really do a randomized controlled trial in women with what you know about estrogen detoxification? Can you really randomize that everyone is the same? if you really wanted to accomplish that, you're not talking about height, weight, age, oophorectomy, no oophorectomy, and metabolites. You'd have to really say that all of those are equal before you actually said that was a control versus randomized,
That's a great point. There's a lot that you'd have to normalize to really look at that one variable a lot more clearly. Yeah. So let's step it back, and I want to talk about this from the perspective of a patient who might be listening. So let's clarify eligibility for HRT for a patient that has a personal history of breast cancer and a family history of breast cancer. Let's start there.
So when you're talking about a family history of breast cancer, we usually try to define it as first degree versus second degree. So first degree would be mother, sister. So even grandmother is not first degree relative. So the degree of relative and actually how many relatives matter. It's not an absolute contraindication, right? So for us in the functional space, we want to know root cause. So what was the cause? Was it premenopausal, postmenopausal? Was she taking hormones? Was she not taking hormones? Was it triple negative? Were the receptors positive? That kind of stuff for a first degree relative. But it's not a reason that you can't take hormones, although people are told that, right? Because if you think about what are the risks and benefits of hormone therapy, yes, there's a risk of breast cancer. And what's the leading cause of death for women? Heart disease. Number 2, stroke. Number 3, lung cancer. Number 4, breast cancer. If you add up the deaths from 2, 3, and 4, you don't equal the amount of deaths from heart disease. And although we can't say it prevents heart disease, we have a lot of observational studies that show it's protective and it's favorable for heart disease. So as a woman with a mother with breast cancer, you still have a higher risk of dying of a heart attack, period, right? And the death rate from osteoporosis-related fracture is higher than the death from breast cancer. So what about if you personally have a history of breast cancer? I can't really generalize that recommendation, but I can tell you that we normally don't want to give estrogen to those. And if you look at the NAMS position statement of 2022, they say for severe vasomotor symptoms that's not amenable to other treatment under the agreement of the oncologist, then maybe you can prescribe breast cancer. So it doesn't even say in the position statement that it's an absolute contraindication to use hormone therapy in breast cancer, but everyone, if you look at the verbiage of it. So what we say is we want you to be 5 years out from your treatment, right? And then a lot of it depends on a lot of things, like what kind of cancer, what stage, what grade, what were your receptors. I have patients who've had breast cancer in their late 30s. And then by their late 40s, they have osteoporosis-related fractures and heart disease. And they've begged for estrogen. And I've prescribed it without any problems so far, right? So age at diagnosis depends. So it's an individual question. I will tell you that most people won't give estrogen to a breast cancer survivor. Now, that position statement by NAMS also says that you can use vaginal estrogen without any concern. However, if you look at the data using Premarin vaginally, there have been some systemic estradiol levels that increase after the use of that. So we always recommend a lower dose estradiol or a different form of estradiol versus estriol or DHEA. DHEA is FDA approved for vaginal use. So that the recommendation is that it is safe to use. There was a recent study done, I don't know if it's Danish or Swedish breast cancer survivors that were given both vaginal hormone therapy and systemic hormone therapy. And they did not see an increase in recurrence when those patients were given hormone therapy. But what they did see is people who are on an aromatase inhibitor, which blocks the conversion of testosterone estrogen, did have a slight increased risk when they're on vaginal preparations.
Oh, that's so interesting.
Yes, it was really interesting. So
you'd think it would not have any kind of impact, or it would have an improvement in rates. But
that's what doesn't make any. Well, see, because if you're seeing testosterone the aromatase inhibitor is blocking any endogenous production in a postmenopausal woman, because it's mostly
estrogens
from those sources, and then you're giving estrogen. But what would be the difference if you weren't blocking that? You'd get that. It seems counterintuitive.
It seems counterintuitive, definitely. Did they see a difference in vaginal estradiol versus vaginal DHEA?
I don't know that the study in breast cancer has been looked at. I think there was
Okay.
an observational study that they looked at breast cancer survivors and vaginal DHEA and no increased recurrence. But the study that I was referring to was serum estradiol levels,
Okay.
where vaginal permin did increase, which if you think about it, you're giving a vaginal, it's getting into the serum. So there is a concern that it could get to the breast, whereas DHEA doesn't raise the serum levels of estradiol
There was actually another longer term study that showed it did for after 6 months.
for
You could
DHEA.
measure changes in estradiol. I can get you that study just
Yeah, that'd be
for your
interesting.
interest. But because we thought
Everything
the
that,
same thing, our team was digging into it before. So, but the whole idea with vaginal hormones, for those of you listening, is that it really, when you insert, especially in the upper third of the vagina, there is a first pass effect within the uterus. So you get actually a lot more of that hormone in the uterus and in that kind of perineal region. And so, especially if a woman's main symptoms are genitourinary, where everything is kind of localized in that area, it's a really nice option because it doesn't raise systemic levels as substantially as a transdermal application or an oral application might. So, the thought is it could be a safer alternative, particularly for someone who you don't want to increase systemic estrogen. But it wouldn't, unless it's done at high doses, it wouldn't address hot flashes. Now, it can be done at high doses as a systemic route of administration also, but that's not done quite as
yeah,
often.
I don't really see how. I mean, I trained with a pharmacist, and so he's just saying labial administration isn't really systemic. I know it's
Mhm.
touted as that, but it's interesting. And the thing about genitourinary symptoms of menopause is they don't go, hot flashes eventually go away, right? But genitourinary symptoms of menopause progress. And
Mhm.
so there was one article that was like, the headline was, vaginal dryness causes death, and it was like an assessment
No,
of
it
like,
just causes discomfort.
well, they were extrapolating that vaginal dryness leads to UTIs, leads to urosepsis, which can be deadly. And I'm like, that's a little bit of a stretch, but I get the point.
Yeah. It's a sign. It's like an early sign of something that could leave you with other risk factors there. That's interesting. So, I want to talk a little bit about, and thank you for clarifying all that information on breast cancer. One of the things I think about often is that there is a lot more consumer awareness of hormones just generally, which is such a wonderful thing. And it's leading women to go into their OB-GYN or their, functional medicine provider sooner during perimenopause with the thought of like, I think I want to get on hormones and can we do it as soon as possible because I'm at that late perimenopause. I'm not menopausal yet, which is 12 months without a bleed, without a period, but I'm perimenopausal. I'm disturbed enough that I want to start this therapy. Do you think that we're going to see trends shift in women who start younger on hormone therapy? When we talk about that breast cancer risk increasing after 5 years, if we're starting hormone replacement therapy sooner, is that going to be a bigger problem for women?
So I absolutely am seeing younger and younger patients in my office. And if you look at my social media demographics, I have more followers that are like 25 to 40 than that are older. So it's interesting. And they're very in touch with their body and being proactive and being healthy, right? I think that what is mostly happening in perimenopause is the use of progesterone. I don't see, I mean, I'm hoping, maybe am I being naive to think that people are prescribing estradiol to people who don't need it? You don't need to wait till 12 months post period, but you do need to wait till estrogen levels are low. You don't prescribe it if the patient, and we were always taught if the patient's having a monthly period, they're making enough estrogen, then they don't need it. Now, for the most part, I would agree with that, with the exception of some hypothalamic, like super skinny people that overexercise that maybe, don't have low estrogens in their 40s. And so it's a good point. Like, what if they are getting estrogen and testosterone and progesterone? And like anything, there's still that controversy about testing. What is traditionally accepted is just prescribe. And so there is going to be some prescribing without checking of levels, and especially in the patient that has had her uterus removed, no ovaries, an IUD, no bleed, an endometrial ablation, no bleed. And if you're not testing hormones and you're starting them, like if you've had your uterus removed and you still have ovaries and all of a sudden you start with hot flashes and you're 43, 45, whatever, they're going to give you estrogen only, which is the last thing you need. What you need is progesterone. You could be making still large quantities of estrogen if there's no testing done it could be an issue. I mean, you're right, but I feel like at least if they're seeking out people that are testing, and even the traditional doctors that are menopause doctors may seem like they might be checking some blood levels, so I'm hoping that it shifts the right way.
Yeah, I hope so too. And certainly, women should, like you said, start when they need it. Progesterone might be the first start, but it does make me think about longer exposure to hormone replacement therapy when we're kind of trending to start a little bit earlier.
So dose
Now,
is going to be key for that, right?
yeah, dose will definitely be key and proper monitoring as
Yep.
well. So, what about non-hormonal options for menopausal symptoms? Are there things that you're using in your practice, maybe for patients who have a high risk and where hormone replacement therapy is not a great option for them?
So one of the important things to remember is hormone therapy doesn't include only estrogen. There's progesterone, there's testosterone, there's DHEA, there's a lot of hormones, there's insulin. So we're working with our patients to optimize all of their hormones. So a lot of times when they have a lot of insulin, they have hot flashes. So all breast cancer means is let's be very careful about estrogen before. Let's try to avoid estrogen unless we can avoid it and the patient is miserable. And then let's do risk benefits. Let's try to get them to the 5 years. But progesterone is questionable. I've given progesterone many, many times to breast cancer survivors, and that has helped a lot of symptoms. I've given DHEA to breast cancer survivors many times. That has helped symptoms, bone health, sleep, everything. There are some herbal supplements that have been studied, and depending on there's been recently a couple complementary studies on the literature. I just saw one that said evening primrose oil, vitamin D, lavender. So it depends on what the symptom is. Is it hot flashes? Is it anxiety? Is it sleep? So the supplement choice or herbal therapy may be a different based on what your symptom is. That's why sometimes people ask me, what's the best supplement for menopause? Well, what's your issue? Is it sleep?
Right.
Or is it anxiety? It's going to be a different recommendation. There is an FDA approved, and I'm not going to be able to pronounce the generic name, so I'm just going to say the trade name, which is Veoza, for hot flashes. It works through the neurokinin receptors in the brain, so it's not hormonal, and it has been approved for hot flashes. The cost is pretty high. But I prescribed that for a young breast cancer patient who is in her 30s, and they're giving her Lupron to shut her ovaries down. Hasn't had any kids yet, so she's miserable with hot flashes. So, but it's pretty costly and probably not covered by insurance. Off-label, actually, I don't know if it's FDA approved or not, but Paxil was often given for hot flashes or Effexor. If you're
I didn't know that. Interesting.
Yes, Effexor was mostly, you're not supposed to give Paxil if they're on aromatase inhibitor or if they're on tamoxifen because it interferes with the metabolism. But these SSRIs, SNRIs, which are usually used for antidepressants, have also been encouraged to use for hot flashes. Again, I can see how it would help mood, possibly hot flashes, not going to help a lot of the other symptoms like low libido of menopause too.
In fact, maybe make it worse with SSRIs don't have a great track
Right.
record when it comes to libido.
Right. So there are some there are a couple FDA approved for low libido that are non-hormonal, flibanserin, which is Addyi. So there's a few things that are available for patients who don't feel they can take hormone therapy.
That's great. The other thing that I would just throw out there for listeners is exercise, which actually has been studied and shown to reduce hot flashes, which is exciting, those lifestyle pieces. And then the other thing I see clinically is just avoiding alcohol. Like alcohol seems to be a big trigger for women, particularly in that perimenopausal stage where hot flashes are starting. So just a couple of things I'd add.
And sugar. And I just did a kind of a review of the literature because I'm doing this workshop at the yoga studio. So I was like, what about yoga and menopause? So actually yoga in one study didn't reduce hot flashes, and some it did. It definitely seemed to help sleep. And the how do they term it? Neuro symptoms of menopause, like anxiety, depression, definitely improved those. It didn't help the symptoms in premenopause or perimenopause, but in menopause it did. So absolutely, exercise is an option. Dietary changes, cutting out the sugar, like you said, the alcohol, especially red wine, seems to precipitate hot flashes. sugar.
Oh, and probably stress management's worth mentioning too. Like I think it's hard. A lot of providers are surprised to learn that postmenopausally, when the ovaries stop producing hormone, pretty much all of our hormones come from adrenal produced
Yep.
DHEA that then
Yep.
gets converted. So DHEA is made by a different part of the adrenal glands than cortisol, but they're actually both stimulated by ACTH. And it's the same process from the brain to tell the adrenals to produce that. So they're made, I wouldn't say in equal amounts. It can vary from person to person, but they're made the same way. So if there's HPA axis dysfunction physiologically, it makes sense that if you had, abnormal cortisol or even kind of a history of that, so you didn't have good communication along the HPA axis, that menopause might be tougher. And interestingly, there's anthropological data that if you look at traditional tribal cultures that still exist, they do have cessation of menses, but across the board, they don't report other symptoms of the menopausal transition, which is fascinating.
Well, yes, because hormone therapy wouldn't be available necessarily in indigenous nations, right? And so when you
Right.
talk about cortisol, there is that feedback of high and low cortisol, but there's no feedback for DHEA. So I'm seeing so many patients through the pandemic, through stress, with really low DHEA. And if you don't check it, the patients don't necessarily know. There's not a signal back to the brain to produce more.
Mm-hmm.
So they can have very low DHEA, and that directly affects how they will experience menopause.
Yeah, that's another reason why I love the Dutch test, because it looks at the adrenal output, DHEA, cortisol, and you can really see, what's happening in totality. And certainly that's something that I like to look at in perimenopause to help women make sure that they're making as much improvement as possible before they
And
hit
for
that
all of my
menopausal
breast cancer
transition.
survivors that I see, if they're able, we run the Dutch test, because there are also studies that correlate flat cortisol curves with not as good of a prognosis for breast cancer. So
Mm. Well, my last question that I want to wrap with is for patients who are listening, who are looking for a provider to support them, especially if they've had breast cancer, but really across the board. I was shocked to learn that only 4% of women age 55 to 65 are on hormone therapy right now. And when you say 100% of women should have it as an option, I don't think that 100% of women are hearing from their providers the full story. And actually, I still talk to providers who have not updated their philosophy since, WHI was released 20 years ago. How can patients find a provider who they can trust to really get the risks and benefits, and not find someone who's really a Yahoo who's over prescribing, but not find someone who is over emphasizing risk? How do we find the right
that's
people?
such a great question. And there are many levels to answering that. First of all, what you touched on is prescriber, right? So the first thing is I do see that patients are coming to a health coach or a chiropractor or a non-prescriber, right? And they may be evaluating your hormones and checking your hormones and helping you with everything, but they're never going to suggest it. And they're never going to be able to sit down and tell you, these are the risks, these are the benefits, I think you should have it, because they're always going to go the non-prescription route because they aren't trained or able to prescribe. So you're not going to get a totally accurate risk benefits ratio unless you go to a provider. I'm a traditionally trained OBGYN. We get zero training on menopause. So
That's insane.
you can't. It is, and and I just thought, I haven't lectured the residents lately because after COVID happened and everything, it was so shut down the hospital. But I used to do 4 lectures a year, and that's all they got.
Yeah.
So I haven't done that lately, so they're probably getting nothing. But don't assume that your OBGYN is trained. So do you go to a certified menopause practitioner? You could go to menopause.org. They have a directory at their site. Keep in mind that to get that designation does require an examination, but that's kind of it. You have to study their book, take the test, and you have to keep it up. And I have to go to give so many hours because I got certified in 2006. And so I have to keep it up and do so much of their education to get the credits. They will at least be able to properly tell you about the literature and the studies and the risks and benefits, just as we outlined per the position statement of the Menopause Society. They are probably not going to check your levels. They're probably not going to titrate your levels, but you won't have to. They won't hesitate in prescribing it if it's an option. If you go to a functional medicine provider, not all functional medicine providers are trained in hormones. So I don't know very much about Lyme disease and mold and that kind of stuff. So I'm certified, I have a board certification. So just because you're going to somebody who has either an IFM certification or an A4M board certification or an integrative medicine board certification does not mean that they are trained in hormones. So for the most part with social media websites, you can vet your provider before. A4M does have a directory and there are little icons to who actually, you could be a member and not have enough education. So you want to look for those that are fellowship trained, board certified. From A4M, Dutch has a directory of providers who are trained to use the Dutch test. Other labs have directories, functional labs that of their people who use their test as far as hormone tests go. So you have to dig a little deeper. And so just going to a functional medicine. So for example, I'm 30 minutes south of Cleveland Clinic and, not all, and they're like functional medicine center, but not everybody is trained for hormones. I just connected with somebody who is, which is nice, but not everybody is. And so it's very difficult to find someone. So I would suggest asking your provider, do you feel that you have training in menopause? How do you feel about, have you had extra training in hormones and menopause? Do you feel comfortable prescribing? If you don't prescribe, because I don't think the practitioner should tell the patient you can't take hormones, right? Our job is to tell them what the risks and benefits are. So if you're not trained, do you know somebody who is? Or can you refer me to somebody who is? Because when a patient comes to me, I'm not doing their PAP and their pelvic and their surgery. I'm not stealing a patient from my colleagues, right? I'm just going to manage their hormones and send them back to them for their annuals. So I think they don't feel threatened by me. So there's a concern that patients have to stick with their family practice doctor or their GYN. You don't have to leave your GYN. You can just go and get your assessment and then, go back for all your gynecological care. But ask your provider. You can't really go to your provider and say, can you check these hormones, right? Because that'd be like me walking into Pizza Hut and saying, I want Greek food. We don't have Greek food here. No, I want Greek food. This is what I want. I want spanakopita. I want, it's a Pizza Hut, right? They don't make anything, so going to a provider, even having a list of these are the things that I want you to order, maybe that provider would order that because they're really open and they want to help you, but they're not going to really know how to interpret the different levels and what's appropriate, when to get your testing done if you're perimenopause, if you're still having cycles. So, you might pay for the blood testing or maybe it's covered, but then people come to me with their testing. I'm like, these are not normal. Oh, I'm told they're all normal. Well, they're not normal, right? So, looking for, if you just want a traditional provider that's not going to necessarily check you, then you could go to a menopause provider, menopause trained clinician. They have a directory, or like I said, A4M, IFM, but making sure you kind of look at their websites. Do they talk about hormone therapy? What do they say? With YouTube and TikTok and everything, you can go and see what you think about the provider, and do they seem like they talk about hormones a lot, or do they talk about Lyme disease a lot?
Right.
So.
And looking for someone who has a balanced view, I think, is really critical, because you want someone that you can trust, someone who's not going to be selling a paradigm, whether that's for or against. That's, I think, so critical. Like, I love that you bring up all these ways to look into it. And if you are a healthcare practitioner, the NAMS menopause certification is not limited to medical doctors. So if you're a naturopathic physician, you could still go through that education, and it's not expensive to take the test. So if you're a provider listening, and this is an area where you want to hone your expertise, one, I think that every provider could benefit from NAMS education, because understanding the literature and understanding the standard guidelines are really critical to be able to practice safely with patients. And if you are deviating from that because of a practice style, that's okay. But you should at least know what the standard is so you can be making a conscientious choice around that. I think their education would be wonderful. And as a provider who, my whole career was cycling females. I do fertility, cycling females and males. Since working with Dutch, we work with so many menopausal women that my last 2 years have been a boot camp. And now I'm so passionate. Of course, I'm starting to start my perimenopausal journey, but my passion for helping women in this space has deepened and grown so much. And I also understand how deep and how complicated the literature can get as you're trying to sort through this decision making, that don't go into it loosely, learn it, dive in. It's very interesting.
But thankfully, there seem to be a lot of more options for menopause care now. There's these pop-up telemedicine companies
Oh,
that are,
totally.
but the perimenopause are where they're still neglected, right? That they're
Hmm.
saying, well, we can't help you because you're not 12 months, or we can't help you, your labs are normal. So that's where I feel called to serve, is the 30s and the 40s, with hormone disorders.
Well, we'll have to have you back to talk about that because there's a lot we could unpack
Right.
around perimenopause. But today, thank you so much. This has been an awesome conversation. I've learned a lot. I'm sure our listeners have loved it as well. So, how can we help you? How can people find more about you if they're interested in connecting with you
Yeah.
further?
So I have a YouTube channel, Tara Scott MD. It might be a Hormone Guru now, which I trademarked. And so it's Hormone Guru MD on Instagram, Hormone Guru on TikTok. Lots of free information up there that patients can take a look at.
Wonderful. Thank you so much.
Thank you.
If you're wanting to learn and really expand your expertise in hormones, you're not going to want to miss our podcast. So make sure you tune in each and every week for our new content.